So now that we have seen what the clinical anatomy of the sinuses is, how infection can go into the sinuses, what is rhinosinusitis and how we manage rhinosinusitis, now let us quickly see what the complications of sinusitis can be. So yes, that is very easy to guess. The complications of sinusitis can be when the infection from the sinuses goes through the adjacent areas. What the adjacent areas are, we already know: the orbit, intracranial. So yes, the main complications comprise these. So complications of sinusitis can be divided into acute and chronic. So we can have acute complications or we can have chronic complications. Chronic complications. Now in the acute complications, the most common complication is orbital complication. Most common is orbital complication. Now if I tell you most common is orbital complication, next thing you will have to tell me, can you tell me which sinusitis will lead to orbital complications most commonly? Ethmoid, frontal, maxillary, sphenoid. All can lead to orbital complications. Out of these, most common is, yes, the ethmoid. So this follows most commonly ethmoid sinusitis. Ethmoid sinusitis. And if I ask you, ethmoid sinusitis is seen most commonly in children or adults? Yes, it is seen more commonly in children. So complication of ethmoid sinusitis, that is orbital complication, will be seen more commonly in children or adults. Yes, this will also be seen more commonly in children. This will be seen more commonly in children. Now, how can infection go from the sinuses to the orbit? Yes, very good, through lamina papyracea. Can there be any other route for this infection to spread to the orbit? Yes, very good. The venous drainage of the ethmoid and the orbit is the same. It is the superior and inferior ophthalmic veins. So yes, the route can be either through lamina papyracea, or it can be through venous drainage. From the ethmoids, the superior and inferior ophthalmic vein, they drain the ethmoid also, the orbit also. So through them, the infection can go into the orbit. And the superior and the inferior ophthalmic vein, do they also drain into the cavernous sinus? Yes, they do. They ultimately go into the cavernous sinus. So the infection from the superior and inferior ophthalmic vein, the infection of the sinuses can reach the cavernous sinus, and it can also lead to cavernous sinus thrombosis. So Chandler divided the infection going from the ethmoid to the cavernous sinus through the orbit into 5 stages. Yes, the first stage, this is what is Chandler staging. The first is that there will be periorbital edema, periorbital swelling. That is what is known as preseptal cellulitis. This is the first stage. And the orbital complications, they usually go from one stage to the other, which means that suddenly in the patient you will not see there is orbital cellulitis. Before that, you will see a preseptal edema, preseptal cellulitis. So here in preseptal cellulitis, there will be edema of the eyelids, and when you open the eyelids of the patient, what you will see is that the eye is looking okay. There is no conjunctival chemosis, the movement of the eye, everything is normal. Now the next in sequence will be orbital cellulitis. So next will be orbital cellulitis, that will be the second stage. Orbital cellulitis. This will then progress to subperiosteal abscess, and then will follow orbital abscess, and that will ultimately can also result in cavernous sinus thrombosis. So can cavernous sinus thrombosis result following orbital cellulitis? Yes, it can. Can orbital cellulitis result following ethmoid sinusitis? Yes, it can. Can ethmoid sinusitis through orbit lead to cavernous sinus thrombosis? Exactly, that is what we have been doing now. Can cavernous sinus thrombosis also occur following ethmoid sinusitis or any other sinusitis without going through the orbit? Which means that can any sinusitis directly also lead to cavernous sinus thrombosis? Yes or no? Yes, it can. Yes, cavernous sinus thrombosis can occur following any sinusitis without orbital cellulitis also. Why? What is the danger area of face? Yes, so this here is the danger area of face. Why is this known as danger area? Yes, because from here, the venous drainage, we have the deep we have the facial vein which communicates with the deep facial vein to the pterygoid plexus. So from the facial vein, we have the deep facial vein. We have the deep facial vein which communicates with pterygoid plexus, and this pterygoid plexus has direct communication with cavernous sinus. Yes, as we can see here, the facial vein through the deep facial vein communicates with pterygoid plexus which has communication with the cavernous sinus. So any cavernous sinus thrombosis directly from the sinusitis also, and the presentation of orbital cellulitis and cavernous sinus is very similar. Why very similar? Yes, why very similar? Because what are the structures that are involved in cavernous sinus thrombosis? So quickly tell me, what are the nerves in relation to the cavernous sinus? Yes, we have the third, fourth, sixth. Yes. So these are the nerves that will be involved in cavernous sinus thrombosis. Can you tell me which are the nerves that will be involved in orbital cellulitis? In the orbit, 3, 4, 6, exactly the same. Yes, so these are the nerves that are arising from the midline, from the midbrain, pons area, and they have to exit the cranium, they have to go into the orbit. So on their way, they encounter the cavernous sinus, so they pass either through the cavernous sinus or they pass around it. Yes, so these are the nerves that will be involved in both cavernous sinus thrombosis also and orbital cellulitis also, which means what I mean to tell you here is that the presentation of orbital cellulitis and the presentation of cavernous sinus thrombosis is very similar. Both of them can follow sinusitis. So in your exam, presentation is given, presentation of the patient is given. Yes, that the patient has sinusitis and following which he had proptosis or he had involvement of third, fourth, sixth nerves. Yes, so some presentation is given and you are supposed to mark the diagnosis. You are supposed to differentiate whether it is orbital cellulitis or a cavernous sinus thrombosis. In the choices, both are given. So how are we supposed to differentiate? Both can follow sinusitis. It is not that always cavernous sinus follows orbital cellulitis only. So yes, this question can be asked because both can follow directly from sinusitis and we need to differentiate them. Why? Because the presentation is very similar. But we know that in cavernous sinus thrombosis, that is a life-threatening condition and it has to be managed very, very aggressively. So we need to immediately differentiate whether this is the patient of orbital cellulitis or this is the patient of cavernous sinus thrombosis. So how do we differentiate? Each and every point is very important. So just note, this will be given as clinical presentation. So these are the points that you need to pick out in the question to come to a diagnosis. So what are the findings that we have to look out for? Now in orbital cellulitis, as I told you, the orbital complications always progress from preceptal cellulitis then to orbital cellulitis. Yes, so first there will be a periorbital edema, then it will progress to orbital cellulitis, then orbital abscess, and later on there will be nerve involvement. Whereas in cavernous sinus thrombosis, the moment there is thrombosis, there will be concurrent involvement. It will be a very acute presentation. Immediately all the features of eye will be present. It will not progress from periorbital edema to progressing to ophthalmoplegia. So all the presentation will occur as a very acute presentation. So the onset in orbital cellulitis is slow onset, whereas cavernous sinus thrombosis is a very acute presentation. Acute presentation, it is a abrupt onset. Now the nerve involvement in orbital cellulitis, yes, it will be 3, 4, 6, whereas in cavernous sinus thrombosis, again these nerves are involved, but which is the nerve out of these 3, 4, 6 which passes through the cavernous sinus? Yes, one of them passes through the cavernous sinus. Which one is that? Yes, the sixth nerve. Two structures pass through the cavernous sinus. One is the sixth nerve and the second is internal carotid. So through the cavernous sinus passes the sixth nerve. What's the significance of knowing this? In cavernous sinus thrombosis, the earliest nerve to be involved will be the sixth nerve. Yes, so earliest will be sixth. Earliest will be sixth nerve, followed by then there will be involvement of third and fourth nerve. Trigeminal paresthesia will be absent in orbital cellulitis. It will be present in cavernous sinus thrombosis. And another very important difference is that orbital cellulitis is always unilateral, whereas cavernous sinus thrombosis, it starts as unilateral and then it progresses to bilateral. Was a recent question of your exam that a patient presents with chemosis, with proptosis following rhinosinusitis, and now there is diplopia in the other eye also. there is lateral rectus palsy of the other eye also. So now what is the diagnosis? Is it a orbital cellulitis or cavernous sinus thrombosis? So whenever there is bilateral involvement, then it is cavernous sinus thrombosis. And in the other eye, what is mentioned is involvement of lateral rectus. So yes, that is the earliest nerve to be involved when there is cavernous sinus. So here everything is involved on one side, and the other side it has just started getting involved. So earliest will be the sixth nerve. So you have to remember all these points to differentiate cavernous sinus from orbital cellulitis. So in this patient, if it is asked that just by image can you diagnose whether it is orbital cellulitis or cavernous sinus thrombosis, can you make out? Yes, if nothing is given. Yes, just by seeing whether it is unilateral or bilateral. Yes, this is probably a orbital cellulitis. The cavernous sinus can also be unilateral to start with. But if they are just giving this much and asking you, then yes, this is a orbital cellulitis. Whereas in this patient, yes, this patient definitely is a cavernous sinus thrombosis. There is bilateral involvement. So in the acute complications of sinusitis, we have already seen that orbital complications are most common, and they are seen most commonly in children. And they can progress from orbital cellulitis to cavernous sinus thrombosis. Now, if the infection goes up till the supraorbital fissure, which means that the nerves that will be involved will now be along with third, fourth, sixth, which extra? Yes, which are the nerves that come through the supraorbital fissure? Third, fourth, sixth, and ophthalmic branch of fifth. So if along with 3, 4, 6, ophthalmic branch of fifth is also involved, that is what we call as supraorbital fissure syndrome. So 3, 4, 6 and ophthalmic branch of fifth. That is the first branch of fifth. Yes, so that is preorbital fissure syndrome. And if along with all this, there is involvement of the optic nerve also. Optic nerve also, that is what is known as orbital apex syndrome. Yes, these terms you need to know. Orbital apex syndrome. So orbital complications are the most common. Now another complication, acute complication of sinusitis is osteomyelitis. Osteomyelitis can involve two sinuses. It can either involve frontal sinus or it can involve maxillary sinus. Either frontal or maxillary. So I have told you this thing, either frontal or maxillary. You will tell me that in children which will be more common, frontal or maxillary osteomyelitis. So which is the last to develop? Yes, frontal. So in children, if we see osteomyelitis, it will be mostly a maxillary osteomyelitis. Whereas if we see in adults, that will be a frontal osteomyelitis more commonly. So most common sinus involved overall in osteomyelitis is frontal. Frontal is most common involved, followed by maxillary. And maxillary is involved in children, whereas frontal is involved in adults. And how does this appear? Yes, this appears like a subperiosteal abscess. Yes, can you see here? The frontal sinus has ruptured and you can see the pus subperiosteal abscess. And this is what is known as, this appears on the outside like a soft doughy swelling here on the forehead. This is what is known as Pott's puffy tumor. This is known as Pott's puffy tumor. Again, this has been asked many a times in your exam. What is Pott's puffy tumor? So what is Pott's puffy tumor? It is osteomyelitis of the frontal sinus. And whenever there is any swelling here, be it a osteomyelitis of the frontal sinus, that is Pott's puffy tumor, be it a osteoma, be it a mucocele, anything of the frontal sinus, eye will be displaced. So the displacement of eye will tell that this is arising from the frontal or the ethmoid. If it is arising from the ethmoid, the eye will be pushed only laterally and maybe forwards. But if it is from the frontal, it will also be pushed downwards. So if the eye's orbit is pushed downwards, that indicates that this swelling that we are seeing here is arising from the frontal. So the eye position will be, as you see here, just note in this patient, can you see the eye is pushed laterally also, the eye is pushed down also as compared to the level of this eye? Yes. So yes, this is pushed, the eye position is laterally and it is down. And how do you manage this? Yes, this is a subperiosteal abscess. As we saw in the CT, there is an abscess that has collected below the periosteum, and abscess anywhere we know needs to be drained. So how do we drain the abscess that is collected here? Will it be possible to drain it endoscopically through the nose? Very unlikely. So we will have to drain it through an external incision. So where will be the incision given? Yes, the incision that we will give is, again, yes, we have read about this incision. Have we read about this incision? This incision is what is known as Lynch-Haworth. This is known as Lynch-Haworth. This is the same incision that we give to ligate, expose the ethmoidal arteries to ligate them. So this is what is known as the Lynch-Haworth incision, and this procedure of drainage of frontal sinus, drainage of Potts-Puffy tumor, or drainage of frontal sinus abscess, is what is known as trephination of frontal sinus. Trephination of frontal sinus. So for trephination of frontal sinus, this is the incision. The third acute complication of sinusitis are intracranial complication. Intracranial. And intracranial complications are very similar to how we discussed in mastoid infections, how the infection goes from extradural to subdural to meningitis to brain abscess. So here also it is very similar. First there will be extradural abscess, then there will be subdural, and then there will be meningitis, then there will be brain abscess. Here the brain abscess was temporal lobe abscess. Here the brain abscess will be frontal lobe abscess. So here there will be extradural, then there will be subdural abscess. It is not necessary that one will follow the other. Only after extradural, subdural will occur. Okay. So that is why I rubbed that arrow. So there can be meningitis. There can be frontal lobe abscess. And there can be cavernous sinus thrombosis. Out of these, the most common is a subdural abscess. Subdural abscess is most common here, and second most common is frontal lobe abscess. How will a patient of frontal lobe abscess present? Will the patient have nominal aphasia? Frontal lobe abscess. Will the patient have pie in the sky appearance or pie in the floor appearance? None. Will the patient have personality changes? Yes, frontal lobe abscess presents with personality changes. And how do the cavernous sinus thrombosis present? Yes, is it a slow presentation or abrupt presentation? Quickly tell me. Yes, abrupt presentation. Which nerves involved? 3, 4, 6. And earliest to be involved is 6. Is it unilateral, bilateral? Yes, it is bilateral. Is there trigeminal paresthesia present? Yes, it can be present in cavernous sinus thrombosis. And which intracranial complications occur most commonly following which sinusitis? Orbital complications occur most commonly following ethmoid sinusitis. Whereas intracranial complications, they occur most commonly following which sinusitis? Following frontal sinusitis. They follow most commonly frontal sinusitis. So these are the acute complications of sinusitis. So quickly tell me, what are the acute complications of sinusitis? Yes, most common is orbital. There can be osteomyelitis. Osteomyelitis is most common of which paranasal sinus? Frontal. Frontal paranasal sinus osteomyelitis is seen most commonly in children or adults? In adults. Yes, followed by next most common osteomyelitis is of maxillary. Maxillary is more common in children. Okay, what is the next acute complication of sinusitis? Yes, intracranial complication. Out of the intracranial complications, most common intracranial complication is subdural abscess, followed by frontal lobe abscess. Now, there can also be chronic complications following sinusitis, and in the chronic complications, it is mainly the frontal sinus that is involved. Why the frontal sinus is involved and what actually happens in frontal sinus chronic complications is that the frontal sinus has a very long duct which drains into the middle meatus. The frontal sinus is present here and it drains into the middle meatus through a duct, frontonasal duct, which is nowadays most commonly known as frontal recess. So now what happens is when there is any infection of the sinuses and the frontal recess is also blocked because of edema. Now once the antibiotics have been given and once the infection is resolved, still this duct is so narrow that any little edema also, if it persists, that can continue to obstruct the drainage of the frontal sinus. So that can lead to collection of secretions in the frontal sinus which is not infective. That is what is known as mucocele. When that mucocele gets infected, that will get converted to pus. That is what is known as pyocele. So the chronic complications of sinusitis can be either mucocele or pyocele. And they follow most commonly, they are seen most commonly in the frontal sinus. And if there is any swelling here of the mucocele. How will it push the eye? How will you know that this swelling is coming from the frontal sinus? Yes, it will push the eye downwards also and laterally also. So eye displacement will be down as well as laterally. So how will we manage whenever there is any complication? Yes, whenever there is any complication of sinusitis that you are suspecting, be it of acute sinusitis, be it of chronic sinusitis, be it acute or chronic sinusitis, the complications of sinusitis are the same. They are acute complications or chronic complications. Whenever we are suspecting any complication, the first thing is to confirm that yes, there is a complication. How do you confirm is by radiological investigations. And the radiological investigation that you will go for, tell me, for the paranasal sinus, yes, it is CT. But now what we are looking for is complication, means it is going into the orbit or it is going intracranially. So will only a CT suffice? No, we will have to go for MRI also. So we will have to go for both CT as well as MRI. We will have to go for CCT here. Yes, CCT, nose and paranasal sinus of the orbit also, and we will go for MRI also to rule out intracranial complication. And always the first management has to be medical. Is that very clear? The management is always medical management. And what is the indication of surgical management in the complications? Surgical management needs to be done when medical management is not working. Yes, if no response to medical management. No response to medical management. Also, if there is any Pott's Puffy tumor, will you like to go for medical management? There is so much of pus that has collected here in the frontal sinus. Will you not have to remove all the pus and debride everything by trephination of the frontal sinus? Yes. So if there is any abscess that has collected, be it a frontal lobe abscess also, be it osteomyelitis also, Pott's Puffy tumor also. So whenever there is abscess, we know it needs to be drained. So whenever there is abscess, orbital abscess also, yes. So whenever there is abscess, we know then the initial management will not be only medical, we have to go for surgical management. So whenever there is abscess, and also in orbital cellulitis, if there are features of optic nerve compression, if there is orbital apex syndrome that we are suspecting. So when there are features of optic nerve compression, then we do not wait. We immediately have to decompress the orbit because orbit all around is bony. If the orbital abscess or if there is orbital cellulitis and the edema is so much that is compressing the optic nerve, then also we immediately have to go for surgical management, decompression of the orbit. So then whenever there is optic nerve compression features. So other than this, for the management of complications also, you immediately have to admit the patient, you have to get the radiological investigations done, and you have to start the patient immediately on IV antibiotics. So that is what you need to know in the complications. Complications are very commonly, quickly tell me, which is the most common complication of sinusitis? Acute complication. Yes, it is orbital complication. Orbital complication occur most commonly following with sinusitis. Ethmoid, it is seen most commonly in children and adults. It is seen most commonly in children. Osteomyelitis is seen most commonly in which paranasal sinus? In frontal. What is frontal osteomyelitis also known as? Yes, it is known as Pott's Puffy tumor. It can be just like a soft doughy swelling here, or maybe it has ruptured and the pus is also leaking out. So that is what is Pott's Puffy tumor. What is the most common intracranial complication of sinusitis? Yes, the most common intracranial complication is subdural abscess followed by frontal lobe abscess. Now just a word about X-rays, nose and paranasal sinuses. Now you must have noticed that wherever we did the lateral wall of the nose, wherever we did the meatuses, the sinuses, everywhere we correlated the anatomy with the endoscopic pictures and the CT pictures. And there in the CT you saw that how the nose looks, how the sinuses looks, how the excessive pneumatization, the named cells of the ethmoid or the structures in relation to the sphenoid, everything they look are exactly depicted the same, perfectly the same in the CT scan. So now you will understand that why I am doing X-rays, just as I said that just a word about the X-rays. Why? Because X-rays are not done nowadays for sinuses, for nose, because of how much information that we can get on CT, we can never get on X-ray. When you see the X-rays now, you will notice that we are hardly able to see anything. But yes, in your exams, X-rays are still asked. So that is why there are some X-rays that we need to know, that we cannot do without knowing. That is what we will be doing now. So yes, the X-ray that we most commonly do for nose and paranasal sinuses is the Waters view. Now the Waters view is the occipitomental view. What is the occipitomental view? Occipitomental means the rays are from the occiput, they are going down, which means that the position of the head is like this. This is what is known as the nose-chin position. I will just show it to you. So this is what is nose, the nose and the chin. The nose and the chin are close to the plate, to the X-ray plate. This is known as nose-chin position. You can remember Waters as water. How do we pour water? It is like this, from up down. So it is an occipitomental view. It is also known as nose-chin position. That is why I showed you how it is done. And just see here, what all are we seeing? So you can drastically compare what you're seeing here from how the appearance of these nose and sinuses are in the CT scan. So here we have the frontal sinuses. Here we have the anterior ethmoids. Now here we have the maxillary sinus. So out of this, if I ask you which is best seen in Waters view, yes, you can make out, that is easy. Yes, the maxillary sinus. So best seen is maxillary sinus. Waters view is usually done with mouth closed. Just notice here that the teeth, both the teeth here, they are approximating. The mouth is closed. There is no space in between the teeth. So this is mouth closed. Now when it is done with mouth open, then this is known as Pieris view. This is done with mouth open. Now here, can you see that the mouth is open? Both the teeth, one teeth is here, the other teeth is here. Can you see that in between these two there is difference? So yes, this is mouth open. When the mouth is open, you can also see the sphenoid sinuses here. So with mouth open, you can also see sphenoid sinuses. You can see sphenoid sinuses also, and this is what is known as Pieris view. In one of your exams 2 years back, Waters view with open mouth was given, what it is known as, and in the choice Pieris view was there. So if it is there in the choice, you will mark as Pieris view. Whereas if it is not there in the choice, Pieris view, this is a term which is rarely used. So the most common, if it is not given, then the most common name that we give to open mouth also is Waters view with open mouth. So if it is just given this picture and it is asked that this is Waters view is given in the choice, you can mark that also. So is that very clear? Now here, what view is this? Can you guess? Yes, this is the lateral view. This is the lateral view. And in lateral view, what are the structures that we are seeing? We have the frontal sinuses here. That is it the superiormost sinus or is the sphenoid superiormost? Yes, we can see that this is the frontal sinus. That is the superiormost because the base of skull is not straight. The base of skull goes slanting down like this. Where are the sphenoid sinuses? So we can see the sella turcica here. So this is the sphenoid sinus. We have the anterior ethmoid. We have the posterior ethmoid in front of the, just before the sphenoid sinuses are the posterior ethmoid, and we have the maxillary. So we can say that all the sinuses are visible in the lateral view. Visible in the lateral view. When we did Waters view with open mouth, which sinus was not visible? In Waters view with open mouth, we were able to see the frontal, the anterior ethmoid, maxillary and sphenoid, which is still not visible. Yes, the posterior ethmoid. How can you see posterior ethmoid in this view? In the anterior view, you cannot see it. You will be able to see it in the lateral view. So if it is asked in your question that all the sinuses are visible in which view? Yes, it is the lateral view. So yes, we can say that all the sinuses are visible here, but what is visible you can also make out, right? Now there is another view which is asked in your exam, and that is what is the Cadwell view. Now what is Cadwell view? It is the occipitofrontal view. So the rays are projected from behind occiput to the frontal region. So here the forehead and the nose is in touch with the film. So it is known as nose forehead or forehead nose position. It is known as most commonly as Cadwell position, and this is best for, we can see here that the sinus that is visible best here is the frontal sinus. So the best sinus that is seen here is frontal sinus. So this used to be the X-ray that used to be done whenever the frontal sinusitis was suspected. Frontal sinusitis suspected means what would be the history? What will be the headache? Mainly it will be in morning, in the evening, yes, early morning headache or office headache. When the patient complained of that, to rule out a frontal sinusitis, when you want to rule out that, then this view was done. Now when, suppose, both these X-rays are given and you are supposed to identify which one is Waters and which one is Cadwell's. How will you be able to identify which one is Waters and which one is Cadwell's? Yes, just see the lower border of the mandible. Yes, here in Waters, can you see? In Waters view, the lower border of mandible is in the form of an inverted U, whereas in Cadwell view, it is straight. Is that clear? So Cadwell is straight, this is Waters. So those were a few X-rays that you needed to know for your exams. And yes, quickly tell me that which sinus is seen best in Waters' view? Maxillary sinus. Waters' view with open mouth also helps you to see which sinus? Sphenoid sinus. And yes, it is known as Peary's view. Yes, if Peary's view not in the choice, then if that picture is given with open mouth, you can also mark that as Waters' view. Which is the best view for frontal sinus? That is Cadwell's view. All the sinuses appear in which view? In lateral view. In lateral view, which is the highest sinus? Yes, the frontal sinus. So that is what you need to know in X-rays.